So why am I here? So I'm a child psychologist by training. One day I was minding my own business working for the County of Orange in the late 90s, and we had this wildfire. Oops, where's the pointer? I'm not sure where the pointer is on this. Oh, okay. Oh, that's cool. So we had this wildfire here. That's actually Pacific Coast Highway. And I got pulled into the fire response for the county. And I had just become a Red Cross disaster mental health volunteer, so I got my trial by fire, so to speak. That launched an interest in acute trauma and ways to intervene at the population level and the individual level for kids and families. I kind of switched to academia, although I straddle these worlds, and it's very interesting to see how they sometimes don't interact very well. I belong to the National Disaster Medical System. I had the honor of being the SME and the liaison officer for the HHS, the ASPR response to Sandy Hook and the Boston Marathon. And I worked with the Joint Advisory Committee for California Department of Public Health and some federal activities as well. And I did have the opportunity to be activated for the CalMAT, which is a state medical assistance team that's under Dr. Backer at CalEMSA. And I went to the Butte County Fire for about 12 days in November, so I had some firsthand experience. So really the issue is, in terms of designing a response, is what are the assumptions we have about what happens to kids and adults in fire and other kinds of acute traumatic events? So theoretically, there's multiple pathways. Probably the most common two are a resilience pathway, which is great. Exactly what that word means, I no longer have any understanding. This is kind of the bounce back idea, which I know that Dr. Jonas has some different ideas about, which I just read and are quite interesting. And then chronic dysfunction, which is essentially a clinical outcome. That's the theory. What the data shows is something very similar. And basically, people, adults and kids, it's extremely common and normative, if you will, to have transitory distress. And those look like PTSD symptoms, but they are not syndromal. So in other words, they don't form all the cluster necessary to make the diagnosis. And critically, they don't have the criteria for functional impairment. So it doesn't cause interference in their ability to function in school or in home or in the community. So things like insomnia, fears of recurrence, which can be in a terrorism or a natural disaster, a fire, those do not add up to a diagnostic category. And what we do for them is, I think, very different than the other side of the equation. And that is that looking at all of the available evidence that's out there, on average, and if we focus on direct victims, people that had a specific impact, they were in the event or they had loss related to the event, 30 to 40% get a new disorder they didn't have before. New incidence disorder, if you will. And I don't really think as a nation or as a state or anywhere else, we've really come to grips with this number. Now, in some events it's much larger, in some events it's much lower, but that's kind of the average. Responders, medical responders, first responders, they also have increased risk, 10 to 20%, much lower than direct victims. But what happens when you have a local responder? You really have the double whammy. So they can have an impact in their response role or their disaster medical role, and also they can have a direct impact from the event itself in their own lives and their own community. So we haven't really dealt with that. And then there's the whole issue of prior severe mental illness or severe emotional disturbance, which is the pediatric criteria, which is a state and a federal definition, and all sorts of health and social disparities tied to ACEs and other sorts of things. They really interact. My own work is about trying to figure out who's likely headed toward a distress but no real disorder, time limited, and who's headed toward new disorder that's going to require something more, than psychological first aid or non-specific strategies. And the reason is, if we get to this high-risk subset within 30 days, which really isn't being done anywhere that I can really see, there is really an untapped preventative window, because there's evidence, a lot with adults, some with kids, that if we get to the high-risk subset within 30 days, maybe 10 days, but definitely within 30 days, I call that the golden month. If we get to them quickly and we link them to relatively brief, manualized, evidence-based interventions, we can reduce, maybe even prevent the clinical trajectory, prevent PTSD from occurring. So for example, there's one study from Australia that looked at an acute injury adult population. They gave them 4 hours of relatively, this manualized evidence-based treatment, and they found that there were reliable differences between the matched controls and the exposed population even 4 years later. So 4 hours gives you 4 years of significant clinical improvement. I think that's a pretty good investment, but for some reason we don't seem to do that a whole lot. Kids, we know by age, are the single highest risk group, and unfortunately with kids you don't even have to have a full diagnosis to have impairment. So even subsyndromal symptoms can cause impairment in schools. Some of the best work longitudinally looking at Katrina, NIMH-funded study with Ron Kessler at Harvard. Basically, you were 5 times more likely to have a new SED diagnosis after Katrina. An SED essentially means you have to have severe symptoms with impairment in more than one setting, so home and school. So it's not just a diagnosis, it's a pretty significant one. And they suggested that 2 years later, 2/3 of the SED status, so the SED cases in greater New Orleans, were related to direct exposure. So that's not resilience, at least in that subset. And somebody mentioned the data from Canada. This is actually looking at adults and basically showing PTSD diagnostic rates and other kinds of diagnoses, depression in the 30% range, which kind of fits what we talked about initially. And then there's ACEs. Where do ACEs fit in? And I think there's a very significant overlap that we haven't fully explored between pre-existing adverse exposure and disparities and acute trauma. This just came out relatively recently. This is not about fire. It's from the Kaiser Foundation looking at Hurricane Harvey. And you can see 3 in 10, 30%, affected residents reported decline in their own mental health, and only 8% received any kind of service. And there's multiple reasons why that occurs that I think we need to really hammer out. We have good evidence-based strategies out there. This is for adults and kids from WHO. This is a national best practice from SAMHSA and the National Child Traumatic Stress Network on child traumatic grief. It's available free. Providers get CEUs, but what's the uptake? So our idea is we need to have an evidence-based way to have decision support. How do we decide who needs what? It's very clear to me that one size doesn't fit all. And in a large degree, I think what happens in mental health is we have a lot of acute responders who go to the scene and chase tears, but we don't really figure out who's at risk and who's not. We don't link them to recovery, to services across the recovery trajectory. This is a model that Ken Wells and some others in New Orleans developed after Hurricane Katrina. And they basically were looking at, gee, if we get to a high-risk subset, and this is actually not a risk subset, this is folks with definitive disorder, in the 7 to 12 months, and we link them to intervention, there would be a significant reduction, out a little bit. I think we can do a lot better than 7 to 12 months. We can get to people before they're symptomatic, the interventions are shorter, they're less expensive for whoever the payer is, there's a lot less secondary impairment. For example, when kids have secondary impairment due to trauma exposure, their attendance goes down. Well, in California, like most states, public schools rely on average daily attendance. There's all kinds of secondary economic impacts. Why wait 7 months if we can figure out who they are? Data from 9/11 basically showing that even in a community where theoretically there's lots of resources, the presumptive PTSD and diagnostic group, only 25% receive timely care. Where do they go? They tend to go into other acute kinds of healthcare services like the ED, where even when you're controlling for their pre-existing healthcare status, they're highly overrepresented. That's true on a daily basis and also in disaster. Is the ED the place to go for disaster mental health trauma care? Probably not. It's a place to get more exposed. We have data from, this is kind of where our research tool came into place after that wildfire in Laguna. And we basically found that when kids experience exposure and it's related to persistent stressors like home loss or home displacement, it triggers all sorts of things. So we found that within the first 9 months, the kids that were displaced from their homes experienced 3 or more moves. They felt that school was much more difficult for them to focus on and be successful. And we found differences in presumptive clinical levels of both PTSD and depression. So when there's home loss, when there's displacement, it's not just the acute trauma and PTSD, it's also depression. I'm sorry, I didn't see the sign. 3 minutes. So here's the bottom line. We need another model. We need another set of tools. Because once you've encountered the hazard, and you're in, you're in active combat situation, combat ops, it's too late to kind of redesign the boat, right? So this is our model, funded by SAMHSA. It's called the National Children's Disaster Mental Health CONOPS. The basic idea is we take population-level risk metrics across various touch points, human service touch points, disaster systems of care, and we do step triage to care. We link the high-risk subset to secondary evaluation. We link them to an evidence-based intervention if they need it and want it, and we try to interrupt that cycle much earlier than usual. And then we link, our current idea is to link high risk using telehealth and web-based interventions. There's some good evidence with adults. The VA actually have a tool out there called PTSD Coach, very effective. But to use that, you have to identify the high-risk group in a timely way. So that's where our triage tool comes into play. We're in LA County, we're in Alameda County, Napa County, 3 or 4 states. We're just launching actually next week for the state of Oregon, Oregon Health Authority. It's in the National Ebola Training Center, which is 10 definitive care Ebola sites. And then linkage of triage information to scalable, cost-effective interventions like telehealth. And basically, our tool identifies risk levels, and then we link individuals at various levels of risk to the appropriate scaled intervention. Looks like that. This is Indiana, using our tool at primary capture points. First responders is kind of their focus. 1 minute. What's different about our system is it's not a PTSD screener. We don't use symptoms. Symptoms are very unreliable indicators of definitive risk. You over-identify people as having a disorder if you just use symptoms, and you also miss perhaps some of the most complex PTSD cases just using symptoms. Avoidance and numbing are clusters of PTSD, and those folks don't respond to those tools at all. So, this kid over here looks upset. Does he have PTSD? No clue. This one, is he chill or is he numb? It's very hard to know using symptoms. So we have a web app where the information is entered using non-professionals, non-mental health professionals. It's what happened, not how are you feeling. Feelings are great 30 to 45 days post. In the initial event, they don't reliably discern who's at risk versus who's having expectable distress. The tool maps real time. So this is actually the Napa data. I'm sorry, no, that's Indiana exercise data. This is what the app looks like. It's very easy to train. It takes under a minute to triage an individual. Tennessee has it, and they've integrated it into all of their other electronic tools. So what appeals to me about this is integrating mental health into the rest of the health emergency response. So we kind of have parity, if you will. This is the way Oregon's pitching it out. It's in some federal policy documents. I'm not sure this changes what goes on in the real world, including an IOM report on crisis standards of care a number of years ago. It's in a catastrophic strategy the state has. We actually used our tool matching up to the FEMA predictive analytics to then generate numbers of people at risk and subdivided by kids and first responders. And then we can do a gap analysis. And then we can figure out how we're going to scale our response. Because if you don't count it, I think it doesn't count. So we have some numbers in there. We just did it for SAMHSA and FEMA for the New Madrid seismic zone. We got really drilled down into the kid portion that we hadn't done actually in the California stuff. This is what the system looks like, exercise data. This is the real Napa data, and then I'll end. This is about 2,700 triage encounters in about 4 days. So this was a collaboration between Napa Public Health and Napa Behavioral Health. And sometimes those two worlds don't mix. They do in Napa, as far as I can tell, and I think that's why this was successful. So they were able to identify a high-risk subset. It shows the average acuity trending over time. It shows the level of comorbidity. We have some data with CDC that basically says the algorithm is probably 2. 1 is not sufficiently specific, overly sensitive. Kind of the optimal sensitivity specificity is in the 2 range. And then we do clusters, so we can then match resources based on what people are actually experiencing, what their risk factors are. Including, we have a component that looks for unaccompanied kids, of which they had 0.4%. And we track each one of we can do trending, controlled for the number of encounters on each one of the risk factors. And there it is mapped. They then took this into their own CONOPS, matching, using the tool operationally to then match resources based on levels of risk acuity. And just finally, this is our largest effort to date, about 20,000 encounters with Red Cross in Superstorm Sandy, aggregated at counties. And just showing you what the system generates. Action strategies, decision points to inform operational decisions. And these are the 2 in high outlier counties. Richmond, Staten Island, low-level barrier island, very high exposures. And this is actually an EPI version that we partnered with CDC after the Napa earthquake. I think this is where Napa County learned of our tool. This is not clinical level data, this is EPI household level data. And we've done that with CDC a few times to get beyond just case definition to actually look at community-wide impact. So, it's all in the implementation. That's what I've learned. Thank you.